Uno era soncelere.
चलो
हाँ
वीडियो बंद कर
वीडियो करा म्यूट
A very good morning to one and all, and I request everyone others to mute their mic before we start the meeting because it unnecessarily creates the disturbance in the proceeding. Sir will be joining in few minutes. Trupti Madam, sir will be joining in 5 minutes. Till that time, we can have the introduction of our organization and other things. We can start. Huh?
Yes, okay, sir. Okay. Namaste and very good afternoon to all respected faculties. Our esteemed speaker, Dr. Prateek Padole, sir, and respected chairperson, Dr. Apala Sengupta, madam, and all participants who are here to attend the webinar. On behalf of our organizing committee members, Dr. Subhash Wage, sir, President and Organizing Secretary, Dr. Avinash Tadke, Vice President, Dr. Santosh Chavan, Secretary, Dr. Vaishali Ganorkar, Treasurer, and Dr. Trupti Yavatkar, Webinar Coordinator. I am working as Associate Professor in Department of Rog Nidan in SC Mutha Haringla Vaidyak Mahavidyalaya, Satara, Maharashtra. I welcome you all for the 25th Naidanic Webinar Series, August 2024, which is approved by NCIM Mumbai and Nagpur University. This is 37th academic activity of our organization. Today, we are here for the third lecture of the series. This particular series of lectures is on the gastrointestinal disorders. As we all know, how much importance is given to Annavasrotas in Ayurveda, which corresponds to the gastrointestinal system. As per Ayurveda, the entire metabolism is governed through the GI tract, and this metabolism is affected in various disorders of the gastrointestinal system. Today's lecture is on the topic IBD, that is inflammatory bowel disease, which is an immune-mediated chronic intestinal condition, which includes two idiopathic bowel diseases, that is Crohn's disease and ulcerative colitis. So to discuss on today's topic, we have among with us the esteemed young energetic gastroenterologist, Dr. Prateek Padole, sir. Before starting our lecture, I would request Dr. Vandana Thakur, madam, to give the brief introduction of our organization, RVPGA. Dr. Vandana.
Thank you, ma'am.
Yes.
Good afternoon to everyone. RVPGA was found in the year 2016 under the able and dynamic leadership of Dr. Subhash Wage, sir. with the aim to give the legal status of pathologist and radiologist to the PGs of Rognidan. Our organization is duly registered under Societies Act of 1860 at Charity Commissioner's Office, Nagpur. PG students and teachers of Rognidan and Vikriti Vigyan and Chaya Vikiran Vigyan and also postgraduates of modern diagnostic subjects can become our members. RVPGA is the only organization which is fighting for the lawful rights of Rognidan and Vikriti Vigyan PG scholars. Even the NCISM had also directed the state of Maharashtra to consider RVPGA as stakeholder in the constitution of pathology regulatory body of the state. RVPGA is pursuing this matter of lab permission with central and state governments. Not only this, RVPGA is constantly pursuing the implementation of NCISM salary structure in all the private colleges across the nation. All the communications and details are uploaded on our website, which is www.rvpganagpur.com. Now, talking about the various activities, they include regular conduction of online webinars and offline seminars, both on national and international platforms. So far, we have conducted 25 national webinars on different diagnostic topics. We have conducted a national conference on X-ray diagnosis at Nagpur. Our second national conference on CT scan diagnosis is scheduled on 20th October 2024 at Nagpur. Hands-on training program for PGs at our partner NABL accredited pathology laboratories at Mumbai, Nagpur, Pune, and other cities of Maharashtra. We have conducted a microbiological hands-on training program for our PGs on 9. Publication of research papers of Nidan students and faculties in our peer-reviewed International Journal of Diagnostic and Research, that is IJDR. Those who are interested can visit the journal website, which is www.ijdrindia.com. It's a matter of pride that
Madam, your voice is losing.
in Government of India's ISBN portal. Those who want to contribute book chapter can visit the RIPI website, which is www.rvpga.iip.com. We have published All India Rog Nidan PG thesis book consisting of all.
Madam, your voice is muted. Vandana madam, kindly unmute yourself.
Okay. We have published All India Rog Nidan PG thesis book consisting of all the Rog Nidan titles since 1985 to 2023 for preference of our chiefs and faculties. This year, we are going to publish the All India PhD thesis book. We are giving legal fight for the issues of Rog Nidan and Vikriti Vigyan PGs at appropriate forums. We have our YouTube channel and Facebook page where you can watch our educational activities past and live. So this was all about RVPJ. Over to you, ma'am.
Thank you, madam. Thank you so much for giving the nice introduction of our organization and its activities. Sir, can we continue?
I just want to lament on few aspects that RVPGA is conducting the National Workshop on Molecular Pathology and National Workshop on X-ray Diagnosis on 19th October 2024, and followed by a national conference on CT scan diagnosis on 20th of October. And this will be followed by our annual award function in the evening. I request all the participants, Nidan participants who have joined us here today to join in that workshops and national conference on CT scan diagnosis in large number. And we are also accepting the participation from not only from Rog Nidan department, but from the Shalya, Shalakya, Kaichikissa, Balrog, all the clinical branches of Ayurveda, because the diagnosing CT scan and diagnosing the X-ray, it is now it has become the basic diagnostic tool, and we should be able to diagnose the to get well acquainted with these new diagnostic modalities. And in Ayurveda, a lot of patients of sciatic disorders, lot of patients of Pakshavada, hemiplegia, those attend the Ayurvedic OPDs, and they come with the CT film. Where is where is the slip disc, where is the disc protrusion, and whether the stroke is hemorrhagic or whether it was thromboembolic. And we need to have sound knowledge of all these modalities, and X-ray is also a basic investigation in most of the disorders. So we should be well acquainted with all the diagnostic criteria of all these basic tools. Not only this, for Ayurvedic pathology students, we are in our in I think in May, in March we have conducted on microbiological diagnosis workshop. Now this time we are conducting it on the molecular pathology techniques such as PCR, RT-PCR, electrophoresis, and these are all new modalities. We should get acquainted. We as a Nidanian, Vikruti Vigyan specialist of Ayurveda, it is our duty to get acquainted with these new diagnostic tools and be in competition and make use of all those techniques in our routine practice. Many of us are now practicing professionally as a pathologist, and it's very important that we acquire these new skills. So I request the participants to join in large number. I think Padole sir had joined with us. I request Trupti madam to introduce this sir.
Yes.
I welcome you, sir.
Yes. Okay. Am I audible?
Yes, sir. Yes.
Am I visible? Oh, sorry.
Yeah. Yes.
Now am I visible?
Yes, yes, sir.
Yes. Okay. Thank you.
Sir, I will introduce. Okay.
Yes. Thank you.
Welcome, sir. Now, I would like to introduce our today's esteemed and distinguished speaker, Dr. Prateek Padole, sir. Sir has done MBBS from St. GS Medical College and KM Hospital, Mumbai, and MD Medicine from LTMMC and LTMGH, Sion, Mumbai. Sir has also done DNB Gastroenterology from Sir Gangaram Hospital, New Delhi, MRCP, that is Magnetic Resonance Cholangiopancreatography from Royal College of Physicians, UK in 2021. Sir is working as Assistant Professor in Department of Gastroenterology at Super Specialty Hospital, JMC, Nagpur, and Consultant Gastroenterologist at KRIMS Hospital, Nagpur. Sir is skilled in diagnostic and therapeutic upper GI endoscopy and colonoscopy, abdominal ultrasound, and liver biopsy, USG guided FNAC, liver abscess aspiration, percutaneous endoscopy, gastrostomy, PEG, tube placement, managed emergencies like GI bleed, foreign body extraction, acute liver failure, severe pancreatitis, etc. since last 4 years. Sir is also skilled in ERCP, including CBD stone extraction, stricture dilation, and metallic stent placement. Along with this, various emergency procedures like endotracheal tube insertion, pleural, CSF, and ascitic fluid paracentesis, pericardiocentesis, central venous line placement, bone marrow biopsy, etc. were handled smoothly. So, with your vast experience in the field of gastroenterology, I welcome you, respected Dr. Prateek Padole, sir, on behalf of our organization. We are honored to have you here, sir, for enhancing our knowledge regarding the topic. I request you, sir, you can start the session.
Thank you, ma'am. Thank you for the kind introduction. Thank you, Vage sir, for the kind invitation. It is an pleasure on my part that I am able to share some of my educational insights with this beautiful forum. I hope this talk helps you somewhere down the line in your practice to diagnose what we will discuss today as inflammatory bowel disease. We would dwell upon some topics. Mostly it is a basic presentation of inflammatory bowel disease, its types, what are its characteristics, and we would also dwell upon some type of treatments, and primarily focusing on the diet part, and some part of the medicine can be also discussed in today's meeting. I hope you are able to look into my slides. Are they shared properly?
Yes, yes, sir, visible.
Yes. Okay. With your permission, I would like to introduce myself. I am Dr. Prateek Padole. I am a consultant gastroenterologist, and I am now into private practice since the last 4 to 5 years. We have been seeing many patients with chronic GI symptoms, and inflammatory bowel disease is one of the most common, most disabling, and most chronic type of disease which we encounter in our practice. It is very important disease because the symptoms are very similar to the other differential diagnosis like irritable bowel syndrome, that is IBS, which is very common. And in this subset of IBS, we should be knowing which patient must be having or would have inflammatory bowel disease. So today's talk will be limited to certain topics, like first we'll introduce about what is IBD, what is the epidemiology and what is the prevalence, what is the importance, why are we speaking on IBD, what are the different types of IBD, what clinical features are there of IBD presentation, how can we diagnose IBD, and we'll dwell upon the management of IBD. We have some slides on the impact of lifestyle factors, the role of diet, and the quality of life and role of caregivers in the treatment of IBD, which is very important because IBD treatment is a multicentric approach. Basically, only the doctor is not plays an important part in the treatment, but the patient has to live with the disease throughout his life. So the first thing we should do is we should educate the patient about the disease. We should be confident, well read, and thoroughly read about the disease. We should diagnose the disease properly, stage it properly, and then plan the treatment accordingly, taking into consideration his lifestyle, his diet patterns, his family conditions, his financial conditions, his work conditions. Is he able to work at his workplace? Can some changes be made in his workplace, in his diet, or in his home? So we should consider all these factors while treating a patient of IBD. To start with, we should first start with the anatomy of the bowel. You should be knowing all the structures of the bowel. A bowel is a wonderful organ. Basically, it is the I would say it's the largest solid or hollow organ in the body. Our small intestine itself is around 6 meters in length. The whole of the GI tract is around 9 meters in length. It is a wonderful organ because whatever we eat has to go through this organ, has to be digested in it, and the important nutrients are absorbed in it. And that is why we require such a long organ, because the amount of absorption is very high in our body. This machine is so efficient that it absorbs more than 99% of whatever we eat. And if we and only 1% of it is excreted either as urine or as feces. So we have not seen such a machine anywhere where whatever is fed into the machine, it just absorbs more than 99% of whatever is fed. And while absorbing this, it also sees that only important nutrients are absorbed. All the bad things should be stayed back, have to be excreted. All the allergens, all the infections have to be controlled at the intestinal site only and prevent them from entering our blood circulation. So that is why I call this a wonderful organ system, because it is doing this all throughout our life. So if it is so complicated, the mechanism is so complicated, we understand that there are many mechanisms going on inside at the molecular level, at the cytological level, and at the macro level, which help the bowel absorb important nutrients and reject which is not good for the body. So the small intestine, it starts from the duodenum after the stomach. It traverses in the abdomen. It is a coil-like structure. It is fixed into the abdominal cavity within the peritoneum. and it ends at the ileocecal junction. It is a very important landmark because it has a valve in it. The work of the valve is to allow the food contents, the enteric contents, to move from the small bowel to the large bowel and prevent the large bowel contents to coming back into the small bowel. So it is a valve. This valve is also important because the different functions of the small bowel and the large bowel are differentiated here. The primary function of the small bowel is the digestion process and the maximal absorption of the nutrients. The primary process of the large bowel is the maximum absorption of water and salts. And that is where our stools get solidified and are excreted from the anus. The large bowel starts from the cecum, it goes into the ascending colon, the transverse colon, the descending colon, sigmoid, rectum, and the anus. So we have talked about the ileocecal junction. We have talked about the various parts of the intestine now. What is inflammatory bowel disease? Basically, as the name suggests, it is a group of chronic inflammatory conditions of the GI tract. It is an umbrella term. Whatever chronic inflammatory conditions of the GI tract may be included in this, but it is majorly categorized into 2 or 3 types, which we'll discuss further. So it is basically a persistent progressive disease that leads to bowel damage and disability. So what we have understood by now is bowel is doing a wonderful job of absorption. And if it is affected by some disease, this job will be affected and it will cause problems in the body. What are the types of IBD? As I told you, majorly distributed into 3 main types. As we have known, there are 2 main types as ulcerative colitis, and the other type is Crohn's disease. The third type is an indeterminate colitis. And why are these types divided? Because one, there is a different pathophysiological aspect of each type. Second, there is a different endoscopic aspect of each type. And third, even clinically, both these types vary much, and the prognosis, the treatment plans are very different for both these types of inflammatory bowel disease. So the differentiation has to be made right at the onset. But many a times, around 5 to 10% of the times, the clinical features, endoscopic features, even the biopsy features may not help us to differentiate between ulcerative colitis and Crohn's disease. And in this situation, we term that entity as indeterminate colitis. We know it is a chronic inflammatory bowel disease, but we are unable to differentiate it into either ulcerative colitis or Crohn's disease. In that first case, which is around 5 to 10% of the times, we label the patient as indeterminate colitis. So basically, we have learned that it is a chronic disease. The patient has to stay with the diagnosis lifelong, even if the disease is relapsing and remitting. That means when it relapses, there are symptoms of the disease, there are endoscopic changes of the disease, and there are changes in the blood investigations of the disease. So this is a relapse. Most of the time, the patient would be in a remission. Remission means the disease is quiescent, both clinically and endoscopically. The patient may feel well, the patient may feel that he is all right and he does not have any kind of disease. But we have to understand that the disease tendency will always be there in the patient, and the patient will have to live with the disease lifelong. What the target of the treatment of these diseases is to maintain the maximum time of remission in the disease. We cannot help or cure the disease. We just have to ensure that the disease has to be quiescent for the maximum time in the patient's lifespan. That is, we have to improve the quality of life of the patient. We have to decrease the complications of the disease, and we have to prevent the malnutrition that may cause due to the disease. So it is a chronic disease following relapsing and remitting course. The relapses, as we have discussed, can be clinical, that is biological, can be endoscopic, or can be histological, that is on biopsy. Many a times, patient will not have symptoms of relapse, like increased frequency of stools, bleeding per rectum, abdominal pain in Crohn's disease. But he may have a endoscopic relapse. That is, the endoscopic features of the disease have increased as compared to before. So now the target of the treatment is not just to suppress the symptoms, but also to ensure that the endoscopic changes are healing. So even if the patient is asymptomatic, we have to look upon inside the patient, that is the patient endoscopically also in remission. And that is the target. We are moving towards higher targets now, that we target a histological remission. That is, at the microscopic level, there should be no activity of disease. When we keep such activity, the patient will remain fine, his quality of life will improve, even his quantity of life will improve. So, as we have discussed, even during the periods of clinical remission, the bowel may not be free of lesions, and there can be subclinical persistence of the disease. IBD, why do we talk on IBD nowadays? Because IBD was very rare in India 2 to 3 decades back, and it was called the disease of the Western population. In India, we used to see lots of tuberculosis, all infective lesions, whatever GI symptoms. We had infection, and infection as the first 3 differentials. But with the change of lifestyle, with the change of diet, stress and addictions coming into play, the prevalence of IBD is increasing rapidly in the Indian population. This has been extensively studied in various clinical studies. And even in the clinical practice, we are seeing increasing number of patients with IBD. So IBD is now a diagnosis of India. We should not hesitate in keeping a differential of inflammatory bowel disease in patients of chronic GI symptoms. And not every patient is a patient of IBS. He can or she can have IBD inside. The incidence is around 6. For ulcerative colitis, the incidence is considered to be more rather than Crohn's disease in India. However, we are also seeing this trend of increasing Crohn's disease in patients who have been previously diagnosed as non-specific ileal ulcers or non-specific colitis or tubercular ileal ulcers. These patients are now coming to us with a diagnosis, and we are diagnosing them as Crohn's disease. So the incidence of Crohn's disease has also increased. The point which I have to drive here is that we should not hesitate in keeping a differential diagnosis of inflammatory bowel disease in our patients. We start with ulcerative colitis. Basically, as the name suggests, it is a disease of the colon, that is the large bowel. It hardly affects the small bowel or other GI mucosa. This has to be very clear. Ulcerative colitis remains only in the colon. The inflammation starts from the mucosa, remains only till the mucosa. It does not traverse deep down into the muscular layer or the serosal layer. It is a continuous involvement. These 3 things have to be noted and made clear in the mind. Remains in the colon, has a continuous involvement in the pathology, and the inflammation remains only in the mucosa, that is superficial. This is ulcerative colitis for you. So it is a continuous involvement. Few other points are generally the inflammation starts within the rectum and progresses further proximally into the sigmoid colon and the descending colon, which may eventually then lead to the involvement of the whole colonic mucosa. Please note here that the inflammation is only in the mucosa. It will not cross deep down inside. That's why we see many superficial changes in the ulcerative colitis. If the involvement is only in the rectum, we call it ulcerative proctitis. If the sigmoid and the descending colon are involved, we call it proctosigmoiditis. And if the inflammation is proximal to the splenic flexure, we call it pancolitis or extensive colitis. So in our language, we call these are E1, E2 and E3 disease. That is, the extent of the disease is defined by these. What are the major symptoms of ulcerative colitis? How will you suspect ulcerative colitis? One presentation is the acute presentation where the patient presents with diarrhea and dysentery, probably because he has increased frequency of stools with passage of mucus and bleeding per rectum. He may or may not have abdominal pain because pain is not a predominant symptom of ulcerative colitis. However, he may have tenesmus, that is a rectal urge of passing feces. Mucus discharge and lower abdominal discomfort are additional symptoms of ulcerative colitis. Either the patient presents to you in the first episode, where your differentials would be either an infective colitis or a first episode of ulcerative colitis. So we have to define the colonic symptoms. When the patient presents with chronic large bowel diarrhea, multiple times he's passing stools which are small in volume, he has rectal bleeding, passage of mucus, tenesmus. This implies the patient has chronic large bowel, that is colonic diarrhea. What are the differentials in this? If he is acutely presenting to us, the first differential should be infective colitis because the symptoms are not chronic. But we should keep in consideration it as IBD presenting for the first time. And that has to be confirmed endoscopically, that is via colonoscopy, seeing the lesions, seeing the types of ulcers, seeing the extent of involvement of the colon, and finally on the biopsy, which may differentiate between acute and chronic changes. If there are chronic changes in the biopsy, the patient may have an acute flare of a chronic disease like ulcerative colitis. If the patient presents in a fulminant stage, he may have severe diarrhea, cramp with fever, leukocytosis, and abdominal distension due to ileus, because the inflammatory load is so much that the abdomen gets distended due to the distension of the colon and the small bowel. How would Crohn's disease present? So the overview, Crohn's disease as opposed to ulcerative colitis, it is an involvement of the whole of the muscle wall. So the inflammation will involve the mucosa, the submucosa, the muscularis, and the serosa. So it's a transmural inflammation. Any segment of the gastrointestinal tract can be involved in Crohn's disease. And Crohn's disease is not a continuous involvement. It generally has skip lesions, means any part of the GI tract right from the oral mucosa until the anal opening. Koi bhi, there would be involvement of any of the these organs. So oral mucosa, esophagus, stomach, duodenum, small intestine, large intestine, and even the anal tract can be involved with Crohn's disease. It is transmural. It involves the whole wall of the GI tract. So it is generally not continuous, and it has skip lesions. So some lesions may be seen in the jejunum, some may be seen in the ileum. There may be multiple ileal lesions. There may be some involvement of the colon. There may be ulcers in the mouth, or there may be large anal sacs in the anus. Generally, the Crohn's disease, which involves the colon, spares the rectum and involves the other part of the colon. The most common sites of involvement are the terminal ileum and the ileum. There may be oral involvement also. In the perianal disease, Crohn's disease would show chronic fissures which are atypical. Generally, we see fissures at the anterior or the 6 o'clock positions, but Crohn's fissures may be seen laterally. There would be thick indurated margins. There may be large anal tags and fistulae. If you see such a patients, which you may be seeing in your practice, please consider Crohn's as a differential, because it may not be a simple hemorrhoid. It may not be a simple fistula or fissure. It may be a complicated fistula or fissure, which needs to be treated very differently than the routine conventional treatment for fissures and hemorrhoids. Because Crohn's fissures and fistulae are often complex, they do not respond to conventional treatment. They may require anti-inflammatory treatment or biological treatment which we give to such patients. And before starting such treatment, we have to extensively evaluate such patients with colonoscopy or a CT scan to see if the other parts of the GI tract are involved so that a diagnosis of Crohn's disease is made. Because there is transmural inflammation, this disease will cause stricturing of the bowel. Ulcerative colitis will not cause stricturing because it is not involving the serosa and the muscle layer. While Crohn's disease involves all the layers, it causes stricture. If it perforates, it causes fistulae, it causes perforation, and it will cause abscess because it will involve all the layers of the bowel wall, perforate into the peritoneal cavity, may cause abscess and inter-bowel strictures and fistulae. In the diagram, we see that how a normal colonic mucosa is seen and how the ulcers and inflammation of Crohn's disease is seen. What are the signs in Crohn's disease? As with ulcerative colitis, patient presents as chronic colonic diarrhea in ulcerative colitis. However, in Crohn's disease, patient can have a myriad of symptoms because it is a pan-GI involvement. He may present with oral ulcers. He may present with non-healing perianal fistulae, perianal tags. He may present with chronic crampy abdominal pain, may present with anemia, vomiting due to GI obstruction, may present it with abscess and fistulae, and malnutrition because there are enteroenteric fistulae. May have non-specific symptoms like anorexia, weight loss, generalized fatigability, and bone loss due to malnutrition. Crohn's is a very complicating disease if it goes out of hand because it is a pan-GI involvement and a transmural involvement, may cause strictures which may cause intestinal obstruction, may cause ulcers in your mouth, in your rectum, in your anus, may cause fistulae which may cause infection and abscesses. So now how do we clinically evaluate these patients? If a patient of UC presents to us, we clinically divide him into mild, severe, or fulminant disease based on the true love and Witts criteria, which includes the number of bloody stools, temperature, pulse, hemoglobin, ESR. So very basic parameters are used to categorize that patient into either a mild disease or a severe disease. This is very important because the further treatment will change according to the severity. When we do a endoscopy or a colonoscopy, we differentiate the staging of ulcerative colitis based on the Mayo score, or there is one more score called UC endoscopic evaluation score, UCEIS. In this, we see different patterns in the endoscopic visualization and differentiate the patient into 0, 1, or 2 score. How do we diagnose these patients? The patient will present to us with some symptoms. We take a negative history. We create clinical examination and create clinical differentials based on clinical examination. Accordingly, we advise the patient some blood investigations and if required, an endoscopy examination and biopsy. Imaging is generally required when we suspect Crohn's disease because endoscopically we can see the rectum, the whole of the colon, and the terminal ileum. It is very difficult to see the proximal ileum, the jejunum, which can be seen easily in the CT scan. But colonoscopy has its advantages because when we see the ulcer, we may take some biopsies for further histopathological diagnosis. So clinically examination, we see for the vitals, signs of extraintestinal involvement. We advise appropriate endoscopies, lab test involved a renal function test, a hemoglobin to look for CRP and inflammatory markers, and imaging like X-ray and CT where required. So what are the differences? We'll just revise. Ulcerative UC is colon only, CD is entire GI tract, UC is continuous, CD has skip lesions, UC is mucosa, CD is full thickness involvement. Bleeding is very common in UC, bleeding is uncommon in CD. Obstruction is uncommon in UC, common in Crohn's disease due to formation of strictures. Perianal disease is uncommon in UC. So you see the minute difference. UC will affect the rectum, but perianally it will be poisoned. UC may perianal, we won't see any lesions. But in CD, the rectum is not so much involved, but there is a perianal disease like fistulae, tags, and fissures. What are the treatment options? It's a general overview. We will not go in details of the treatment, but what we use is 5-aminosalicylates. We may use antimetabolites. Corticosteroids are required in many such patients, and thiopurine metabolites like azathioprine can be used. In certain subset of patients, we may have to escalate the therapy and may use anti-TNFs like infliximab, adalimumab, and golimumab. We may use anti-integrins like vedolizumab, JAK inhibitors like tofacitinib, and interleukin antagonists like ustekinumab. So these basically antibodies are anti-inflammatory in nature. And if we suspect to be a patient having a severe disease, we may use these anti-inflammatories. So in UC, we generally use the step-up approach. If the disease is mild, we use 5-aminosalicylates and see if there is control. If it increases, we may add oral steroids. If it increases further, we may use anti-inflammatories like thiopurines or infliximab. And finally, if the patient is refractory to the therapy, or if the patient presents with complications like colonic perforation, colonic malignancy, we suggest colectomy in such patients. So colectomy is not the routine. Most of the patients are controlled, have remission in medical therapy. In Crohn's disease, we start the treatment with a locally acting steroid like budesonide. We may add thiopurines like azathioprine, and if required, other biological therapy like infliximab and adalimumab. Surgery is generally avoided in Crohn's disease because in the perisurgical site, there is recurrence of inflammation and strictures. However, if there is a limited disease of ileocecal junction, which is a stricturing type, surgery may help in such patients. As we had discussed earlier, not only the doctor needs helps in the treatment, there should be changes in the lifestyle and dietary patterns in such patients because many patterns affect the nature of the disease. Patients should have adequate sleep. There should be stress relief. Treatments like meditation and cognitive behavioral therapy help in achieving remission in such diseases. Patients should be physically active, should avoid being overweight or obese. Physical activity will also help relieving stress on the mental part and decreases the relapses of the diseases. Alcohol and smoking direct relation is not seen. However, we ask our patient to quit such addictions. The role of diet is very much because whatever we eat goes into our bowel, and the things we eat actually act as antigens for our bowel. And if these antigens are altered, the reaction to the antigens will be altered and the disease course may alter. That is why diet plays a very important role. However, in our guidelines, there are no specific diets which are recommended for patients with IBD or no specific diets which are avoided in IBD. However, our clinical experience suggests that some food changes should be done in the treatment in IBD. I'll skip the slides on malnutrition. This is what I was talking about. In our clinical practice, what we ask the patient is that because every patient will ask us, what changes should we do in our diet? There are no specific recommendation. But if eating something for multiple times, and if you get a relapse of symptoms in your disease, then you should avoid those diets. Many a times, if there is a stricturing disease, we ask the patient to eat a low residue or low roughage diet. We ask the patient to avoid salads and dry fruits and those things which are raw, which are high in insoluble fiber, because these may cause constipation and obstruction. We ask the patient to avoid the trigger foods. For many of them, it would be spicy food, oily food, or food which is uncooked. For such patients, we should avoid such food. There are certain food which should be blanketly avoided because they would increase the inflammation in our bowel. These include red meat, which includes beef, lamb, pork, processed meat, and like bacon, hot dogs, and sausages should be avoided. Coconut oil, palm oil, and dairy fat should be avoided because these food increase the inflammation in the bowel. Which foods should be increased in the diet? So fruits like bananas, raspberries, and mixed fruits can be used very often. These help in reducing the inflammation. Vegetables like cooked carrots, not raw carrots, but cooked carrots and green beans will help. Foods rich in omega-3 fatty acids like fatty fish, walnuts, and flaxseed meal can be taken. Other healthy foods include cooked starches, potatoes, sweet potatoes, rice, and oatmeal, and green leafy vegetables after cooking them properly and thoroughly can be used. I'll not go into details of restrictive diet in IBD. So the nutritional approach depends upon what type of clinical scenario we are facing. If the patient has a stricture, as I discussed, we can eat soluble fiber, but we should avoid insoluble fiber and roughage, that is salads and broccolis. If there is inflammatory disease, we should avoid the inflammatory diet as we discussed. If there is a complicated disease with fistulae or abscess, the patient has to be may require surgery or an parenteral diet if he is not tolerating a enteral diet. So what we should also discuss amongst patient is the quality of life. We should ask if he's having a good night's sleep. We should ask if he's married. Is he having or he or she is having a good sexual life? We should ask about his diet. We should see if he's able to work at his workplace, if he's able to manage his relationship. We should also counsel about his mental status. Many such patients, because they are having chronic disease, are often depressed and are anxious about their disease. So we should also help them and counsel them on this part. The role of caregivers is important. Basically, the caregivers should also be well informed and educated about the disease. They should know what is a flare, what is a relapse of the disease, and when to seek and approach a medical practitioner. They should be taught about this. They should be taught that it is a chronic disease and the treatment should be chronic and when to get medical advice. So in summary, IBD is a group of chronic, progressive, inflammatory conditions of the GI tract, and they cause bowel damage and disability. Ulcerative colitis and Crohn's disease are the two main types of IBD, and they follow a relapsing and remitting course. There are several compounds in the diet that have influence on the course of the disease, and diet and along with medical treatment, the primary target of treatment is that we have to keep the disease quiescent, that is in the in remission and help the patient pass through this complicated disease along with them. I thank you all for your patient listening, and I may invite some of the questions. If you have any doubts, I may answer online. Thank you.
Thank you. Thank you so much, sir, for your valuable guidance regarding IBD, inflammatory bowel disease, its pathology, complications, management, lifestyle changes, etc. Definitely, all the participants must have benefited after hearing your lecture. Now, we will move towards the expert chairperson's comment. I would like to introduce our today's chairperson, respected Dr. Apala Sengupta Madam. She is MD and PhD in Rog Nidan. She has teaching experience of 23 years in PG College. She is working as professor and HOD, Department of Rog Nidan at Institute of Postgraduate Ayurvedic Education and Research at SVSP, Kolkata. She has published papers more than 50 in various journals, delivered lectures and presented papers in various national and international platforms like 9th WAC, Asiatic Society, CME, Nidana Samsiddhi at AIIA, etc. She has also guided more than 30 students as PG guide. With this short introduction, I invite you, madam, for the expert chairperson's comment.
Hello. Am I audible?
Yes, ma'am. You are audible.
Thank you. Thanks to the organization of Rog Vigyan PG Association for and I will give special thanks to Dr. Subhas Wagaji, as you have selected me as a chairperson in this session, and I will, the topic that you have selected today, that is inflammatory bowel disease, is a very important and significant topic, because in our Ayurved clinic, majority of the patients are presenting these disorders. And Dr. Prateek Padole sir has given a very nice and classic lecture, and his presentation is excellent, and he had covered every aspect of the clinical disorder, as the causes of inflammatory bowel disease, the pathogenesis of inflammatory bowel disease, how the diagnostic tool, the investigation to be done, and lastly, he has given a very, very valuable expertise and his experience about the diet and lifestyle disorder and lifestyle management regarding these two diseases. He has very nicely given us the idea about the indeterminate colitis, where the patient are in between the ulcerative colitis and Crohn's diseases, and in he had nicely mentioned about the diet, what are the diet to be taken, and his all his presentation is very much classic and excellent, and he had given us a new idea about the diagnostic tool about these two diseases, that is Crohn's disease and ulcerative colitis. And there is no questions from the audience, and I think his lecture, Dr. Prateek Padole's lecture, had enriched us to so in future we can utilize his valuable expertise, and he had highlighted about the clinical aspect about these two diseases. So thank you, the organizers, and Dr. Prateek Padole sir, Dr. Subhasji sir.
Madam, we can take one or two questions if there are any in chat box or audience can ask directly.
Yes, yes.
Yes, sir. All the participants, if anyone has any query, you can type it in the chat box. It's a request to all participants.
Hello.
If there are no questions, then we can move on to the next part, that is vote of thanks.
Okay, sir. Yes, if anyone has the question, you can type it in the chat box.
Hello, I have question.
Hello, sir, you can type it in the chat box. Your voice is not clear.
Yes.
I have
Your voice is not clear. You can type in the chat box. Sir, may I ask a few? Prateek sir is there? Prateek sir, can you hear me?
Yes, yes.
Yeah. Regarding the prognosis and outcome of the disease, with the introduction of newer therapies and anti-immune therapy, particularly, what your experience is, just please share with us.
Immune therapy is in a specific subset of patients. One subset is that in Crohn's disease, the approach is very different in ulcerative and Crohn's. In Crohn's disease, if the patient is young, if he's presenting with perianal disease, if he has a stricturing disease and the inflammatory load is high, we can directly start such patients with biologicals. So this is called the top-down approach in a certain subset of patients in whom the disease is very aggressive. Suppress it at the onset, then gradually then step down the treatment. Whereas in ulcerative colitis, it is a step-up approach, wherein we start with low-dose treatment and gradually escalate our treatment. So in such subset of patients where there is aggressive inflammation, biologicals help to improve the quality of life and also the lifespan. And that is why this approach is now being considered in some subset of patients.
And can we guess now about after going into many patients and many such cases about the relapse and remission?
Most of the patients remain of ulcerative colitis remain in remission for many years. But around 10 to 20% of such patients will have a repeat flare or a relapse of disease in 1 year. So if the patient has presented with flare today to me, there is 10 to 20% chance that he will have a repeat flare in the same year. But most of them don't have flares for 1 year, 2 years. Many of them have long follow-ups. They are in remission for 4 to 5 years also. But we have to make a note here that we need to continue the treatment to maintain that remission. It is very difficult to keep the patient off treatment. There are some patients who are better even after stopping the treatment, but it is not the rule, it is the exception.
Some 20-25 years back when we used to see these patients, and that time, though complication rate was still that time also, it was less, but the toxic megacolon and the perforation used to happen in some patients. Do you notice such complications with the newer treatment advances we have now?
Ulcerative colitis presenting as complication has decreased a lot because for the last 1-2 decades, patients there are treatments available. Patients are if the patient is compliant, the patient is educated, complications don't occur much. The complications are toxic megacolon, perforation, excessive bleeding, and malignancies. So if he's on a chronic remission, these complications are very rare.
Thank you very much, sir.
So we are having 1-2 questions in the chat box.
The question is, can UC or CD cause GI malignancy? Yes, they can cause GI malignancy. It is a known complication. UC after 1 decade, 8 to 10 years of diagnosis of UC, you should undergo a screening colonoscopy every 2 to 3 years, even if you don't have any symptoms. So after a decade, you have to undergo a colonoscopy for screening of neoplasia, that is cancer. The other question is the stage at which this has to be started. Biologicals in CD, as I had discussed, certain subset of patients who are aggressive inflammators, there we have to start biologicals right at the onset. Like young patients, stricturing disease, perianal disease, high inflammatory load, anemia, in such patients, biological should be started upfront.
I think Prateek sir has lost the link. But he had given the answer. Hopefully it satisfies the query. With today's talk, we came to know about the advances in the treatment some 20-25 years back when we were having these patients and we used to give this the sulfasalazine, mesalazine, and the steroid enema, local steroid enema. And even after that, patient used to complain that there was no remission of the complaints. And we also witnessed the agony of the patients. And that time we witnessed our helplessness. But I think with this newer advancement in techniques, it is certainly a boon for the patients. And thanks to the modern medical science, which is exploring the newer and newer options to relieve our agony. Thank you very much, one and all. And let us move forward for the formal vote of thanks.
Yes, sir.
Prateek.
Now we will move towards vote of thanks. Now I request Dr. Rajashri Ambore madam to give the vote of thanks. Dr. Rajashri madam.
Namaste. Can you hear me, ma'am?
Yes, yes.
First of all, I would like to thank our today's speaker, Dr. Prateek Padole, sir, for delivering such an informative lecture on topic inflammatory bowel disease. Next, I would like to thank our chairperson, respected Dr. Apala Singupta ma'am, our organization introducer, Dr. Vandana Thakur ma'am, our webinar coordinator, Dr. Trupti Avalkar madam. Big thanks to webinar organizing President and Secretary Dr. Subhash Wage sir and Dr. Santosh Chauhan sir. And thank you, Nagpur University and MCIM. Lastly, I would like to thank all the sincere audience for joining and listening the webinar. Thank you so much for giving me this opportunity. Thank you.
Thank you so much, Dr. Rajashri madam.
Thank you once again, all. And I declare this meeting is over
Hello,
now.
am I audible?
Yes, sir. Your link,
Sir,
you lost the
yes,
contact.
I am
person.
connected. Yes. Sir, I have unstable communication. I would like to thank all the faculty members and this forum for inviting me. And I'm sorry I have to leave early a bit. I hope this session will help you a lot in your future clinical practice. Thank you, sir.
Yes, definitely, sir. And again, thank you for accepting our invitation and in a single request. And you are always there for us. Whenever we contact you or whenever we request you, you are always there to deliver. Thank you. Team RVPG is very much thankful to you. And it's wonderful to get associated with you. Thank you.
Thank you, sir.
Thank you, sir.
So I declare this session is over.